Welcome to Trauma Matters, a podcast series inspired by the Connecticut Women's Consortium's quarterly publication in partnership with the Connecticut Department of Mental Health and Addiction Services. Trauma Matters is dedicated to the dissemination of information on trauma and best practices in trauma-informed care. In this episode, Cheryl Ken, licensed clinical social worker, asks the expert, Dr. Gabor Maté. Gabor Maté is a Hungarian-born Canadian physician with a background in family practice and a special interest in childhood development and trauma, and in their potential lifelong impacts on physical and mental health, including autoimmune disease, cancer, ADHD, addictions, and a wide range of other conditions. Now retired from clinical practice, he travels and speaks extensively on these and related topics, both in North America and abroad. His best-selling books have been published internationally in over 25 languages. Dr. Maté's approach to addiction focuses on the trauma his patients have suffered and looks to address this in their recovery, with special regard to indigenous populations around the world. His book, In the Realm of Hungry Ghosts, Close Encounters with Addiction, Dr. Maté discusses the types of trauma suffered by addicts and how this affects their decision-making later in life. He is also widely recognized for his perspective on attention deficit disorder and his firmly held belief in the connection between mind and body health. He has authored 4 books exploring topics including attention deficit disorder, stress, developmental psychology, and addiction. Our interviewer, Cheryl Ken, is a psychotherapist, trainer, and consultant who for the last 25 years has committed her life to healing trauma. She is currently a certified trainer for EMDR Trauma Recovery HAP and is an advocate for best practices in trauma-informed care. Her work lies in evidence-based clinical foundations and is informed by contemporary dynamic mind-body approaches as well as by Eastern thought. We thank her for being a regular contributor to our Trauma Matters newsletter. Without further ado, here's the full interview. The first question was cut off in the recording, so I'll repeat it. Cheryl asks, how did you enter the field of trauma treatment?
I was in family practice for 27 years, and 7 years I was also a palliative care physician. And I began to see in family practice that the people who got sick, whether it's physical and mental illness or addiction, there was multi-generational trauma. You just couldn't miss it. Because as a family physician, you get to see families, not just individuals after they're diagnosed. And then I got into addictions, and there with the highly addicted population, everybody was highly traumatized. Mm-hmm. And unfortunately, they don't talk about these things in medical school. Medical schools don't talk about trauma. They just don't. No. The word's not even mentioned in 4 years of most medical people's education. Right. But in practice, if your eyes are open, you can't help but see it. That's the one side. The other side is my own personal history with my own diagnosis with ADHD and depression, and then how I transmitted my own unresolved trauma to my children. Mm-hmm. So I started both in clinical practice, plus I had to come to terms with it in my own personal life. And then I did all the research, at least I reviewed all the research, and it all came together. So it's clear to me now that trauma is the fundamental template for virtually all human dysfunction.
Mm-hmm, mm-hmm, mm-hmm. And so, moving on to the second question, over the span of your entire career, what has been kind of the most crucial or the most crucial revelation that you've that now influences your beliefs about trauma, or just about how you view things? What
the recognition that when you trace the origins of people's dysfunctional patterns, you're always looking at adverse childhood experiences, and the new science that's not even that new anymore, that shows that even brain development itself is heavily influenced by the environment and by the quality of child-parent or child-nurture relationships. And that in a society such as we live in, where parents are so stressed and often so traumatized themselves, you have a preponderance of childhood conditions that then predispose to adult conditions. and it's all relatable to early childhood trauma. So it wasn't the one specific event. It was the overwhelming flow of experience and information that at some point it became totally clear to me that almost virtually everything that I was treating as a physician, from mental to physical illness, to addiction, to ADHD, to everything else, had to do with what we can call childhood trauma.
Mm-hmm, mm-hmm, mm-hmm.
And that it's all preventable.
Mm-hmm,
So that these conditions that we think we're stuck with, they're not genetically determined, and they're not random events. They're actually preventable human experiences.
So if you were to speak directly to mental health and medical providers, practitioners across the board, what significant concept would you want to impart? What do you think they really need to understand to effectively treat those who've experienced trauma? What would you say to them?
What mental health practitioners need to understand is that the diagnoses that we make are descriptive conveniences, but they don't explain anything. In other words, a diagnosis of ADHD or schizophrenia or depression or anxiety or whatever else, or personality disorder or PTSD, they describe a set of symptoms. They describe a syndrome, but they say nothing about causation, and they explain nothing about the internal experience of the individual.
Mm-hmm.
And that really, these symptoms, or these constellation of symptoms that we call diagnoses, are really either attempted compensations for or direct responses to traumatic experiences. And then unless we deal with the underlying trauma issues, we're not really helping people. We're dealing with surface manifestations. I have nothing against medications, for example. I've taken them myself. But they're symptom relief. They don't address causes. Mm-hmm. And those causes we can address them, and those causes are reversible, actually, with the proper treatment, even in adults. So I think maybe Dr. Judith Lewis Herman is one of the people that you've interviewed. Mm-hmm. Anyway, Dr. Herman is a psychiatrist at Harvard.
Yeah.
Are you hearing me now?
Yes, yes.
Yeah.
Oh, okay.
I was talking about Dr. Judith Herman.
Yes,
she's a psychiatrist at Harvard, and she, in the 90s, she wrote a book called Trauma and Recovery, in which she argued that there's only one psychiatric diagnosis, which is complex post-traumatic stress. Mm-hmm. Now, I just reread that book recently, and she was talking about the victims of trauma. She does not talk about the perpetrators of trauma, but actually the perpetrators of trauma are also victims of trauma.
Yeah.
And, but anyway, the point is that doesn't matter what I totally agree with her point of view that there's only one psychiatric diagnosis, complex post-traumatic stress, but that can take many forms, more than the forms that she listed. It doesn't just take the forms of the victimized individual, it's also the so what I was saying is that not only it doesn't just describe the victims the way Dr. Herman did, based on research at that time, it also describes the perpetrators, and it's all about the multi-generational transmission of trauma. So the people that perpetrate trauma on others are themselves traumatized. Mm-hmm, mm-hmm. Anyway, point being, the message to healthcare or mental health practitioners is that so long as we're focused only on a diagnosis and only on what we call symptom management, we're not dealing with underlying causes. And that there's something else I want to say about trauma, which is that we tend to think of trauma as the terrible things that happen. So trauma is having been beaten or abused or sexually mistreated. That's not the trauma. The trauma is actually what happens in the individual as a result of those events. In other words, the trauma is not just some past event. The trauma is what lives with us and determines the way we function. Mm-hmm. But that can actually be transformed. That can actually be healed. So if we recognize that the borderline personality is simply a defensive compensation, mm-hmm. or that the depression was a way of coping with unbearable emotions, or that the ADHD was a way of somewhat dissociating from stressful circumstances, all of which then become programmed into the brain and the personality. Now we're talking about reversible dynamics. We're not talking about diseases.
Right.
I mean, disease model is one way to look at it, and it's helpful to a certain degree, but ultimately it fails because it doesn't look at the whole conglomeration. And so that these things are reversible dynamics. And if we only focus on controlling the identified disease or suppressing or mitigating the symptoms, we're not dealing with the whole individual, and we're not actually giving them the best possible opportunity to heal.
So within the given context of the way that, trauma is not talked about in med school, there's not really a place for it, what approaches would you support or give advice to in terms of where to start, or what would you recommend in order to become a better clinician or medical provider in viewing individuals through this lens and with trauma? What would you suggest?
Well, we like this phrase very much. We keep talking about evidence-based practice.
Yeah.
So that's a great phrase if only we applied it. So I say let's look at the evidence.
Yeah.
Let's look at the voluminous evidence on how early experience, including intrauterine experience,
Yes.
and perinatal and postnatal first years, how those experiences actually shape the brain, how they actually shape the circuitry of the brain, the neurochemistry of the brain, neurotransmitter levels, receptor numbers, circuitry, system integration, all these key circuits that are involved in mental health or mental dysfunction are actually shaped physiologically. So when we talk about biological psychiatry, let's look at the source of the biology in human experience. And then let's look at the evidence on early childhood experiences and adversity and the outcomes in terms of physical and mental illness. So let's look at the child developmental literature and the attachment research that has been done so elegantly now for decades.
Yeah.
And let's bring this all together. So let's bring the interpersonal neurobiology, to quote Dan Siegel's phrase, and the developmental biology of the brain together with attachment theory, they're both really different sides of the same coin, along with the adverse childhood experiences studies and so many other extensively researched dynamics. And so let's look at the evidence, and let's base our practice on the evidence, not based on some kind of outmoded theories of genetic diseases and narrowly biological entities and simply categorizing people by DSM criteria. So let's look at the actual evidence. And so my fervent wish is that the medical and healthcare practitioners in general, mental health practitioners, actually look at the evidence. So unfortunately, we don't have evidence-based practice right now, or we have practice that's based on a very narrow definition of what evidence is. Mm-hmm. None of what I'm saying is in the least controversial, actually, if you look at the research evidence, which has been published in bona fide major medical journals and psychiatric and psychological journals and so on. So it's not like you have to dig far and deep for it. It's available. There's a kind of we need to get over our ideological limitations and the limitations of specialization and look across the board. All these fields that really complement each other need to be clinically coordinated and brought together to fully serve our clients.
Right. That is such an important message. And in terms of approaches, do you have any recommendations in terms of treatment, direct, concrete treatment approaches that you value or that you support in your practice? And
Well, trauma is a very complex phenomenon, and it fundamentally it reflects a disconnection from oneself, both in the psychological and emotional and physical sense. And that means that treatment needs to include the physical, the emotional, and the psychological.
mm-hmm.
It needs to include a real exploration of people's core beliefs about themselves, which in the case of traumatized people, there's always some sense of worthlessness and shame. And that's just one example. On the emotional level, our capacity to feel our emotions and to be able to have access to them and to be able to act on them in a healthy way and not to be able to have emotional self-regulation. So that has to be addressed. The alienation from the body has to be addressed. People need to actually get back into their bodies, get out of their heads and into their bodies, and that may involve play and dance and drumming and yoga or somatic experiencing or sensory motor processing, any number of modalities that people have developed and are teaching. But of course, EMDR has been shown to be a very helpful modality in dealing with traumatic experiences. So we need to have a very broad, non-exclusive, and multifaceted approach, and interdisciplinary. There should be much more coordination between people that provide care. Physicians need to be very humble about the limitations of what we learned and what we know. And we need to contribute what we can, but we need to work with other professionals who are far more adept, for example, at addressing body dysmorphia or disconnection from the self, or any number of things that doctors just aren't trained about. So anyway, we need to have a broad approach that looks at all facets of the individual. And some people might even say there needs to be a spiritual perspective, which goes beyond the limitations of the egoic self and looks at our connections to the larger universe. But all these things have to be brought, all these facets have to be brought into together for a complete treatment, I think.
Okay. And for the final question, you're writing a book called Toxic Culture?
Well, the book I'm working on,
Yeah.
Actually, I retitled it.
Oh.
I haven't written it yet. I'm going to call it The Myth of Normal, Illness and Healing in a Toxic Culture. Yeah. So
could you talk just a quick little bit about that?
Well, we look on people's problems as individual issues. Like here's a person with depression, there's another person with asthma. Actually, understanding the science, which is that, like take a simple fact. Black American women, study this year, the more experiences of racism they have, the greater the risk of asthma. So that's not big news, because we know that stress has a lot to do with asthma. That's been known for decades, and the physiology of it is very straightforward. I won't go into it now, but it basically has to do with the derangement of the body's immune and stress mechanisms. So what we end up treating asthma with stress hormones, adrenaline and cortisol. Now, so stress then, it relates to asthma. But stress can be found emanating from many sources. The one source of stress is economic inequality. Another source of stress is racism.
Right.
So asthma, is that an individual problem or is it a social problem? Is the fact that stress on the parents an individual issue, or is it a social issue? Obviously, it's a broader social question. So when you look at a country like the United States, where 70% of adults above age 50 are on some medication, at least on one medication, 50% have some kind of chronic illness, that's 50%. Now, if in the laboratory I was growing microorganisms in a culture broth, in a petri dish, and 50 or 70% of them are sick, I would say that's a toxic culture. There's something about that culture medium that's making people sick. Well, I'm saying the same thing about our society. There's something about this culture, this society, that actually makes people sick. And those factors are identifiable, and so that in understanding illness, whether it's physical illness or mental illness, it's not enough to look at the individual. Certainly, it's not even enough to look at just the multi-generational family. You have to look at the culture in which that family exists and struggles. And so, if you look at a simple fact like the spreading epidemic now of opiate overdoses, which is helping to reduce the lifespan of the white middle class in the States. Mm-hmm. Well, why are people turning to painkillers? Because they're in so much pain, emotional pain. Why are people in emotional pain? Because there's something about this culture that is stressing them beyond their capacity to deal with.
Right.
So the source of addiction, for example, is not simply individual predisposition or genetics or just even personal history. It's also broad social events and social dynamics. Wow. So that's what I mean by a toxic culture.
Wow. Well, I can't wait till you finish that book.
Thank you for listening to this episode of Trauma Matters, and stay tuned for more. You can find this interview as well as a full archive of our newsletters on our website at womensconsortium.org.